Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 293 of our pharmacotherapy series, which majors in heart failure. The first question refers to patient JAJ in part 291 of this pharmacotherapy series. Along with furosemide, JAJ was started on 10 mg of lisinopril daily. Are there specific ACE inhibitors approved for use in heart failure with reduced ejection fraction, abbreviated as HFrEF patients? As a general rule, formulary decisions are first based on comparative pharmacologic activity, efficacy, and drug safety. Other factors to consider are labeled FDA-approved indications, convenience of dosing schedule, and, all else being equal, the cost to the institution and the patient. Hypertension is the primary indication for all of the ACE inhibitors. Not all ACE inhibitors have an indication for heart failure. ACE inhibitors inhibit ACE, also called kinase 2, reducing the activation of angiotensin II, a major contributor to the undesired hemodynamic responses to heart failure. Decreased circulating levels of norepinephrine, vasopressin, neurokinins, luteinizing hormone, prostacyclin, and nitric oxide also have been noted after administration of ACE inhibitors. In addition, ACE is responsible for degradation of bradykinin, substance P, and possibly other vasodilatory substances unrelated to angiotensin II. Thus, part of the beneficial effects of ACE inhibitors is caused by the accumulation of bradykinin. After attaching to bradykinin 2, abbreviated as B2 receptors, vasodilation is produced by stimulating the production of arachidonic acid metabolites, peroxidases, nitric oxide, and endothelium-derived hyperpolarizing factor in the vascular endothelium. In the kidney, bradykinin causes natriuresis through direct tubular effects. The net effect is that ACE inhibitors regulate the balance between the vasoconstrictive and salt-retentive properties of angiotensin II and the vasodilatory and natriuretic properties of bradykinin. The effects of ACE inhibitors are reduced pulmonary capillary wedge pressure, that is preload, and lowered systemic vascular resistance, abbreviated as SVR, and systolic wall stress, that is afterload. Cardiac output increases without an increase in heart rate. ACE inhibitors promote salt excretion by augmenting renal blood flow and reducing the production of aldosterone and antidiuretic hormone. The beneficial effects on renal blood flow, coupled with the drug's indirect inhibition of aldosterone, lead to a mild diuretic response, a distinct benefit compared to hydralazine. Vasodilation and diuresis are not the only value of ACE inhibitors in heart failure. Angiotensin II enhances vascular remodeling, whereas bradykinin impedes this process. ACE inhibitors impede ventricular remodeling by blocking the effects of angiotensin II on cardiac myocytes. Evidence as to whether preserving bradykinin levels affects remodeling is inconclusive, although it might attenuate the progressive deposition of collagen during the chronic phase of post-MI cardiac remodeling. There is no reason to favor one ACE inhibitor over another except in the case of optimizing dosing schedules for patients and trying to use once-daily dosing if possible to improve medication adherence rates. Numerous placebo-controlled trials have documented the favorable effects of ACE inhibitor therapy on hemodynamic variables, clinical status, and symptoms of heart failure and demonstrated a consistent 20% to 30% relative reduction in heart failure mortality. ACE inhibitor therapy is generally better than other vasodilator regimens, including the hydralazine nitrate combination or angiotensin receptor blockers after considering efficacy and tolerability. Of the 5 approved agents, the best evidence for improved survival is available for enalapril in both chronically symptomatic patients, that is New York Heart Association classes 2 to 4, and asymptomatic patients with evidence of an impaired ejection fraction after an MI. The ACEIs guidelines recommend selecting an ACE inhibitor that has shown reductions in both morbidity and mortality in clinical trials in half-ref. The following ACE inhibitors are considered first-line options based on clinical trials: captopril, enalapril, fosinapril, lisinopril, perindopril, quinapril, ramipril, or trandelapril. Captopril and lisinopril are both active as the parent compound and do not have active metabolites. All other ACE inhibitors are prodrugs that require enzymatic conversion to active metabolites. Captopril has a short duration of action, necessitating 3 times daily administration in most patients. Although this characteristic may be advantageous when initiating therapy by allowing closer assessment of early side effects, for chronic maintenance, it is preferable to use a drug that can be given either once or twice daily. All other ACE inhibitors meet this criterion. Package insert labeling and common standards of practice have led to twice-daily dosing, especially at higher doses, for enalapril, quinapril, and ramipril. JAJ's physician chooses to start lisinopril 10 mg daily based on evidence of clinical efficacy, improved survival, and availability as a generic medication. If there were concerns about hypotension, then captopril would be preferred during the initial 1 to 2 days of initiation therapy to avoid dropping the patient's BP too quickly. The next question reads, what is the target dose of lisinopril in JAJ? Do all patients need to be titrated to target doses? Clinical evidence shows a relationship between the degree of improvement in heart failure symptoms and the dose of drug given. Larger doses are more likely to improve the patient's quality of life and reduce the incidence of hospital stays, but the impact of larger doses on mortality is less clear. At the same time, higher doses are associated with a greater risk of side effects. The guidelines recommend that ACE inhibitors be initiated at low doses, and titrated to the maximal tolerated target dose. Supporting this principle are the results of the assessment of treatment with lisinopril and survival trial. Lisinopril 2.5 to 5 mg, that ISS low dosage, or 32.5 to 35 mg, that is high dosage, was given to over 3,000 patients. All-cause mortality did not differ significantly between the two groups. In the high-dose group, hospitalizations and the combined end-point of death and hospitalization were reduced by 24% with a p-value equal to 0.003, and 12% with a p-value equal to 0.002, respectively. The higher dose was tolerated by 90% of patients assigned this dose. Despite these recommendations for using the highest tolerated doses, evidence also suggests that lower doses are beneficial. The UK Heart Failure Network study found that 10 mg of twice-daily enalapril was no more effective than 2.5 mg twice daily. Mortality, evaluated separately, was 4.2%, 3.3%, and 2.9%, for low, that is 2.5 mg twice daily, moderate, that is 5 mg twice daily, and higher, that is 10 mg twice daily, dosages respectively, and not significantly different. The guidelines recommend prescribing doses that have reduced the risk of cardiovascular events in clinical trials, and if trial doses cannot be achieved, then lower doses should be used. For lisinopril, the recommended starting dosage is 2.5 to 5 mg per day. For older patients or those with other risk factors, systolic BP below 100 mm of mercury, those taking large doses of diuretics, or those with pre-existing hyponatremia, hyperkalemia, or renal insufficiency, the starting dose of 2.5 mg per day would be more appropriate. This dose, or an equivalent with one of the other drugs, should be considered if the patient is being started directly on a long-acting drug without prior titration on captopril. For a patient such as JAJ who has already been treated with captopril for 2 days with no evidence of intolerance, a 10 mg dose is appropriate. The long-term target dosage of lisinopril for JAJ is 40 mg daily. No clear formula exists for deciding how quickly to titrate to this dose. It depends on the degree of reduction in his heart failure symptoms and side effects, and motivation to take the medication. Whenever dosage adjustments are made, it may take as few as 24 hours for the patient to perceive symptom reduction, but generally full hemodynamic effects are not reached for 1 to 2 months. Hypotension and other side effects are more immediate. JAJ should have his dose reassessed in 1 to 2 weeks to determine whether he can tolerate a dosage increase to 20 mg daily. A serum creatinine and potassium should be ordered at this time to assess the safety of titrating the ACE inhibitor. Thereafter, a doubling of the dose could occur every 2 to 4 weeks. Thus, it could take 2 months to titrate upward to 40 mg daily. If JAJ's symptoms do not improve, but he has no side effects, titration can occur more quickly either by shortening the assessment periods, e.g., every week, or by using larger dose increments. The next question reads, when should an angiotensin II receptor blocker be used in JAJ? Several clinical trials in heart failure have shown the therapeutic benefit of angiotensin II receptor blockers in modifying heart failure symptoms. A meta-analysis combined data on all-cause mortality and heart failure-related hospitalizations from a total of 17 clinical trials comparing an angiotensin II receptor blocker with either placebo or an ACE inhibitor in patients with heart failure. Angiotensin II receptor blockers favorably improved exercise tolerance and ejection fraction compared with placebo. However, they were not superior to ACE inhibitors in reducing all-cause mortality or hospitalizations for heart failure. The first major clinical trial comparing an angiotensin II receptor blocker with an ACE inhibitor in patients with heart failure was the evaluation of Losartan in the elderly, abbreviated as the ELITE study. Losartan was compared to captopril. For the primary endpoint, a sustained increase in renal function decline, the two drugs performed identically with 10.5% of subjects in each group having a greater than 0.3 mg per deciliter rise in serum creatinine. An unexpected finding was an insignificant trend toward more deaths from all causes in the captopril group, 8.7% compared with Losartan, 4.8%. The follow-up ELITE 2 trial was specifically designed to test the hypothesis that Losartan was superior to captopril in terms of reduction in mortality and morbidity in patients 60 years of age or older. No significant difference was seen in all-cause mortality, sudden death, or all-cause mortality plus hospitalization. Although angiotensin II receptor blocker treatment was not superior to ACE inhibitor therapy, it was better tolerated. Specifically, significantly fewer patients experienced cough with the angiotensin II receptor blocker. The Valsartan heart failure trial, abbreviated as VAL-HEFT, was a double-blind, placebo-controlled study to measure the morbidity and mortality of HFrEF patients given Valsartan. Patients were randomly assigned to receive Valsartan or placebo twice daily. There was no significant difference in all-cause mortality between the Valsartan group, that is 19.7%, and the control group, that is 19.4%. Nearly 93% of patients in both groups were receiving an ACE inhibitor. Dizziness, hypotension, and renal impairment all occurred more frequently in those treated with Valsartan. Further post-hoc analysis found that within the 35% of subjects taking the combination of an ACE inhibitor and a beta blocker at baseline, the addition of Valsartan as a third drug was associated with a trend toward increased morbidity and a statistically significant increase in the combined endpoint of mortality and morbidity. The overall study results suggested that a combination of Valsartan and an ACE inhibitor reduces morbidity, but not mortality. More worrisome was the implication that the three-drug combination of Valsartan, an ACE inhibitor, and a beta blocker adversely affects morbidity and mortality. The Valsartan in acute myocardial infarction trial, abbreviated as VALIANT, of stable patients after MI with left ventricular dysfunction, was designed to test the hypothesis that Valsartan alone and in combination with captopril ACE inhibitor would improve survival. In the VALIANT trial, 70% of the patients were also receiving beta blockers. All-cause mortality, the primary endpoint, was identical in all groups. In addition, an increased rate of side effects was seen in the combination ACE inhibitor or angiotensin II receptor blocker group. Interestingly, among the subgroup of patients taking beta blockers, no evidence was found of harmful interaction with triple therapy. As a result of the VALIANT trial, the FDA approved the use of Valsartan in patients at high risk after a heart attack, and in those with heart failure. The best evidence addressing the efficacy and safety of angiotensin II receptor blocker in heart failure comes from a series of 3 investigations known collectively as the Candesartan in Heart Failure Assessment of Reduction in Morbidity and Mortality, abbreviated as the CHARM trial. The individual components of the CHARM program are A. CHARM alternative, B. CHARM added, and C. CHARM preserved. All 3 investigations were randomized, double-blind, placebo-controlled trials that enrolled adult patients above 18 years of age with at least a 4-week history of symptomatic New York Heart Association Class 2 to 4 heart failure. Subjects randomly assigned to Candesartan were started on 4 mg and titrated to 32 mg once daily, as tolerated. Some standard therapy, diuretics, beta blockers, digoxin, spironolactone, and ACE inhibitor was continued. For all 3 trials, the primary endpoint was the combined incidence of cardiovascular death, heart failure hospitalizations, or both. The differences in admission criteria and outcomes among the individual trials are discussed below. CHARM alternative enrolled 2,028 subjects who met all of the inclusion criteria defined above plus 2 additional criteria, an ejection fraction of 40% or less and intolerance of ACE inhibitors, such as cough, 72%, hypotension, 13%, renal dysfunction, 12%. Thus, subjects in this group received either an angiotensin II receptor blocker alone or placebo without an ACE inhibitor. A 23% reduction was found in the primary outcome of cardiovascular death, hospital admission for heart failure, or both in the Candesartan group compared with placebo. The overall incidence of drug discontinuations because of adverse events was not statistically different between Valsartan and placebo, but there were significantly more reports of symptomatic hypotension, increased creatinine levels, and hyperkalemia in those treated with Valsartan. The CHARM-added trial attempted to determine whether the combination of an ACE inhibitor plus an angiotensin II receptor blocker offered any clinical advantages compared with an ACE inhibitor alone in patients with symptomatic heart failure with an ejection fraction of 40% or less. At baseline, 55% of the patients were treated with beta blockers and 17% with spironolactone. The addition of Valsartan to an ACE inhibitor and other usual heart failure treatments led to a 15% relative risk, with a p-value equal to 0.011, reduction in the primary outcome of cardiovascular death, hospital admission for heart failure in the combination group compared to the ACE inhibitor alone group. It is interesting to compare the result of the CHARM-added trial with those of the Val-Heft study. In Val-Heft, 93% of the subjects receiving the angiotensin II receptor blocker Valsartan were concurrently receiving an ACE inhibitor. The combined endpoint of morbidity and mortality was significantly reduced with combination therapy in Val-Heft, but mortality alone was not reduced. A trend toward more deaths in the small subgroup receiving the triple combination of a beta blocker with an ACE inhibitor and angiotensin II receptor blocker was observed, whereas beta blocker use had no adverse effect in CHARM-DED. The combined results of all three CHARM components, CHARM-added, CHARM-alternative, and CHARM-preserved, see discussion of CHARM-preserved in an earlier case, were reported in the CHARM overall trial. This composite analysis evaluates the benefits of Valsartan in symptomatic patients with heart failure, regardless of left ventricular systolic function. A different primary endpoint was chosen for the CHARM overall analysis, all-cause death. Although the combined results failed to detect a clinically significant reduction in all-cause death between Valsartan and placebo, 9% reduction, with a p-value equal to 0.32, significant reductions were seen in cardiovascular death, 12%, hospital admission for heart failure, that is 21%, and combined cardiovascular death or hospital admission for heart failure, that is 16%, which was the primary endpoint for the individual trials. The CHARM-added trial attempted to determine whether the combination of an ACE inhibitor plus an angiotensin II receptor blocker offered any clinical advantages compared with an ACE inhibitor alone in patients with symptomatic heart failure with an ejection fraction of 40% or less. At baseline, 55% of the patients were treated with beta blockers and 17% with spironolactone. The addition of Valsartan to an ACE inhibitor and other usual heart failure treatments led to a 15% relative risk, with a p-value equal to 0.011, reduction in the primary outcome of cardiovascular death, hospital admission for heart failure in the combination group compared to the ACE inhibitor alone group. It is interesting to compare the result of the CHARM-added trial with those of the Val-Heft study. In Val-Heft, 93% of the subjects receiving the angiotensin II receptor blocker Valsartan were concurrently receiving an ACE inhibitor. The combined endpoint of morbidity and mortality was significantly reduced with combination therapy in Val-Heft, but mortality alone was not reduced. A trend toward more deaths in the small subgroup receiving the triple combination of a beta blocker with an ACE inhibitor and angiotensin II receptor blocker was observed, whereas beta blocker use had no adverse effect in CHARM-added. The combined results of all three CHARM components, namely, CHARM-added, CHARM-alternative, and CHARM-preserved, were reported in the CHARM overall trial. This composite analysis evaluates the benefits of Valsartan in symptomatic patients with heart failure, regardless of left ventricular systolic function. A different primary endpoint was chosen for the CHARM overall analysis, all-cause death. Although the combined results failed to detect a clinically significant reduction in all-cause death between candesartan and placebo, 9% reduction, with a p-value equal to 0.32, significant reductions were seen in cardiovascular death, 12%, hospital admission for heart failure, 21%, and combined cardiovascular death or hospital admission for heart failure, 16%, which was the primary endpoint for the individual trials. The next question reads, JAJ presents to the outpatient heart failure clinic with an annoying productive cough after 6 weeks of lisinopril therapy. His chest examination reveals no evidence of wheezing, with only a few crackles, his neck veins are only minimally elevated over normal, his ankle edema is 1+, and his weight is stable. All laboratory values are normal. Could the cough be a symptom of his heart failure or is it ACE inhibitor-induced? What are the recommendations for managing an ACE inhibitor-induced cough? Cough can be a sign of heart failure in patients with pulmonary congestion. In extreme cases, patients have cardiac asthma, with severe air hunger, wheezing, and dyspnea. However, JAJ's heart failure is much improved as evidenced by the objective data. The absence of wheezing and no prior history of asthma or smoking make an obstructive airways disease, such as asthma or chronic obstructive pulmonary disease, unlikely. It is possible that he does have bronchitis, but he does not report having a cold or other respiratory illness preceding the cough. Without other causes, an ACE inhibitor-induced cough is most likely. This side effect occurs with all ACE inhibitors. Cough is a well-established complication of ACE inhibitors and presents as dry and non-productive, sometimes described as a tickle in the back of the throat. This complication can arise within hours of the first dose, or it can present after weeks to months of treatment. Although resolution of the cough usually occurs within 1 to 4 weeks, in some patients it can persist up to 3 months after discontinuation of therapy. Bradykinin accumulation within the upper airway and decreased metabolism of pro-inflammatory mediators such as substance P or prostaglandins are proposed mechanisms of ACE inhibitor-induced cough. These chemicals then act as irritant substances in the airways to increase bronchial reactivity and induce coughing. Various case reports have found an incidence of cough in 5% to 35% of all patients. The incidence is dose-independent. One investigator found a 5% to 10% incidence in white patients of European descent that rose to nearly 50% in Chinese patients. There may also be a higher incidence in women and black populations. Because this is a pharmacologic effect rather than an allergic reaction, dose reduction or switching from one ACE inhibitor to another is generally not helpful. The only way to definitively diagnose the drug-induced cough is to discontinue therapy. Even then, false positive results can occur if the patient had a mild case of bronchitis that spontaneously resolved at about the same time that the ACE inhibitor was discontinued. If the cough persists after drug discontinuation, other causes should be investigated such as coexisting gastroesophageal reflux disease or allergic rhinitis. For patients with persistent cough, angiotensin II receptor blocker or hydralazine isosorbide are safe alternatives. Therefore, JAJ can continue taking lisinopril for another couple of weeks to determine whether the cough will resolve on its own. His symptoms of heart failure have abated since the initiation of ACE inhibitor therapy, and the cough may be no more than an annoyance. He is not at risk of experiencing asthma or other airway problems. If his cough persists, an angiotensin II receptor blocker is probably the best alternative. The next question reads, what other side effects of both ACE inhibitors and angiotensin II receptor blockers need to be monitored? Does changing from an ACE inhibitor to an angiotensin II receptor blocker reduce the risk of any of these side effects? The ACE inhibitors, and angiotensin II receptor blockers, have the potential to raise serum potassium concentrations via indirect aldosterone inhibition and other neurohormonal actions. For most patients, the magnitude of increase in serum potassium concentration from ACE inhibitors and angiotensin II receptor blockers alone is relatively small, but the risk of developing hyperkalemia is greater if the patient has compromised renal function or advanced heart failure. Combination therapy of an ACE or angiotensin II receptor blocker with potassium supplements, or potassium-sparing diuretics, further accentuates the risk of hyperkalemia. Several case reports and case series have reported hyperkalemia and hospitalizations secondary to spironolactone in patients with heart failure. This became more evident as prescribing patterns for spironolactone dramatically increased after publication of the RAILS study. Not only was there a significant increase in the number of prescriptions for spironolactone for patients with heart failure, but doses higher than those recommended by the clinical trials were often used, especially in patients with evidence of pre-existing renal dysfunction. In addition, evidence indicated inadequate monitoring of serum potassium, renal function, and concomitant drug therapy. Although concurrent use of a potassium-wasting diuretic, thiazide or loop diuretic, may counteract potassium retention from spironolactone or other drugs, ACE inhibitors, angiotensin II receptor blocker, it is nearly impossible to predict who will exhibit hyperkalemia, hyperkalemia, or remain normokalemic. Each patient must be assessed individually for personal response to various drug combinations. Close monitoring of serum potassium is required. Potassium levels and renal function should be checked in 3 days and at 1 week after initiation of therapy known to affect potassium, and at least monthly for the first 3 months. Next we will look at angioedema. Angioedema, also known as angioneurotic edema, is a severe, potentially life-threatening complication of ACE inhibitor treatment. Characterized by facial and neck swelling, with obstruction to airflow by laryngeal and bronchial edema, this reaction resembles anaphylaxis. The mechanism of ACE inhibitor induction of angioedema is unknown, but is thought to be hypersensitivity to accumulated vasodilating kinins. Some, but not all, persons with drug-induced angioedema have a history of familial angioedema associated with a genetic defect in their complement system. ACE inhibitors are contraindicated in this population. In one series of case reports, 22% of the reported angioedema reactions occurred within 1 month of starting therapy, with the remaining 77% arising from several months to years later. Black patients and women may have a higher prevalence. Of concern is the observation that ACE inhibitor-induced angioedema is often misdiagnosed. It is prudent to avoid all ACE inhibitors in any patient with a history of angioedema from any cause. Because the mechanism of ACE inhibitor-induced angioedema is thought to be caused by kinin accumulation, changing to an angiotensin II receptor blocker might be an option. Several case reports, however, have implicated candesartan, Losartan, and Valsartan as possible causative agents of angioedema. In some cases, the subjects had previously experienced angioedema with an ACE inhibitor, indicating possible cross-reactivity, whereas others were ACE inhibitor naive. A small but potential risk for angiotensin II receptor blocker-induced angioedema in patients who are ACE inhibitor intolerant comes from the CHARM alternative trial. Of 39 patients with a history of angioedema while taking an ACE inhibitor, 3 experienced angioedema on candesartan, although only 1 of the 3 actually discontinued taking candesartan. For now, it is prudent to assess risk-benefit, and angiotensin II receptor blockers should be used cautiously in the management of patients who have angioedema from ACE inhibitors. We will now look at the effects of angiotensin-converting enzyme inhibitors and angiotensin receptor blockers on kidney function. Glomerular filtration is optimal when intraglomerular pressure is normal. The balance between afferent flow into the glomerulus and efferent flow exiting the glomerulus determines the intraglomerular pressure. A drop in afferent flow or pressure occurring as a result of hypotension, volume loss, hypoalbuminemia, decreased cardiac output, or obstructive lesions such as renal artery stenosis can significantly lower intraglomerular pressure and lead to impaired renal function. Similarly, long-standing hypertension can damage glomerular basement membrane capillaries and cause renal insufficiency. In the case of low pressure or low flow states, the renin-angiotensin-aldosterone system is activated to maintain intraglomerular pressure. A key factor in preserving glomerular pressure is efferent vasoconstriction mediated by angiotensin II. Increased efferent pressure helps to maintain intraglomerular pressure by impeding blood flow out of the glomerulus. When patients with low-pressure states are given ACE inhibitors or angiotensin II receptor blockers, the protective mechanism of efferent vasoconstriction is inhibited and GFR decreases to a modest degree, resulting in an increase in serum creatinine. By decreasing afterload, cardiac output may improve after ACE inhibitor or angiotensin II receptor blocker therapy, thus preserving or even enhancing renal blood flow. If, however, starting ACE inhibitors or angiotensin II receptor blocker leads to a rapid decrease in systemic BP that is not followed by an increase in cardiac output, worsening renal function may ensue. It is impossible to predict which event will occur. Therefore, ACE inhibitor or angiotensin II receptor blocker therapy needs to be started with low doses, and careful monitoring of the BP and renal function should occur as dosages are increased. Renal function and BP should be checked before and 1 to 2 weeks after initiation or dose increase. Patients with risk factors such as pre-existing renal insufficiency or concomitant treatment with NSAIDs or high-dose diuretics may require more frequent monitoring. Diuretics are not contraindicated, but the diuretic dosage may need to be reduced to avoid overly aggressive diuresis and the accompanying volume depletion and hypotension. The guidelines recommend caution when prescribing ACE inhibitors or angiotensin II receptor blockers in patients who have low systolic BPs, that is 80 mm of mercury, increased serum creatinine, that is above 3 mg per deciliter, bilateral renal artery stenosis, or serum potassium above 5.0 milliequivalents per liter. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 294.